Welcome back and thanks for staying with us. This is still Rapid Done right here on Rapid Television. And of course, right now it is time for the big conversation. My name is Victor. Okay.
My name is Martha Alu. Good morning and welcome to the big conversation today.
And of course, on the big conversation today, we are going to be focusing on the future of healthcare in Nigeria. And of course, just to set the picture clearly, Nigeria's health system is still under pressure. Well, according to the World Bank and WHO health indicators, 2024 to 2025 data, Nigeria spends about 4 to 5% of its GDP on health, which is below the 15% Abuja Declaration target set by the African Union countries. Also, most healthcare costs are still paid directly by citizens. Now, in simple terms, many Nigerians pay out of pocket every time they fall sick instead of relying on strong health insurance coverage. And on manpower, WHO aligned estimates show that Nigeria has about 0.4 doctors per 1,000 people, which is far below global recommendations, leading to long waiting times and heavy workload on medical staff. The result is clear: unequal access to healthcare, with better services in cities like Abuja and Lagos, while many rural communities still struggle with basic care. So the big question we're asking today is, how do we build a healthcare system that is affordable, accessible, and strong for over 200 million Nigerians? And to help us understand this, we are joined by Professor Chima Onoka, a professor of public health and health systems economics. Professor, good morning and welcome to the big conversation this morning.
Good morning. Good to be here.
Thank you so much, Professor, for joining us on the conversation this morning.
Thank you.
Yeah, welcome. Let's begin with let's begin with the current reality. Recent global health data shows that Nigeria still spends less than 5% of its GDP on health, which of course is far below the 15% Abuja Declaration target that was set by the African Union countries. Also, at the same time, over 70% of healthcare spending is still out of pocket. In fact, you recently mentioned that as well in one of your studies in the University of Nigeria in the chapter branch. You said 72% basically, but also saw that about 70 to 70% of the healthcare spending comes from out of pocket, of Nigerians. Now, what does this level of underfunding mean for the average Nigerian trying to access healthcare today?
Okay, thank you very much. That amount, there are many ways of thinking about it. One is the actual value which will end up translating to how much healthcare that can be purchased, right, basically, or paid for. That's one. And then you can also look at it from the part of whether it is adequate. Is it adequate? And then there's also the bits about how it is spent. So I would say that for the average Nigerian, there's a lot that is said about the 15% declaration. I mean, it's just probably a couple of countries that have reached there, especially because there are other demands that, in the other economic demands, whether it's infrastructure, that everybody is pressing for funds. So you might not get 15%. Even though it's said as, it is declared as an aspiration, you might not get there. And there are just a couple of countries that probably got there. But the important thing is that the money that is available needs to be used well. And the challenge is that if, like you mentioned, money is being spent out of pocket by people who have need for healthcare, then that's not a good way of spending money. And any health system that its out-of-pocket expenditure is high has a problem. The health outcomes will not be good. People will be denied care. Those that try to spend will end up facing, being tilted towards poverty because they have to spend. And then what they can buy with the money that they have, you can also not guarantee quality. So access is compromised, quality is not guaranteed, and many people, of course, you end up having high, whether it's deaths or morbidities, illnesses will persist and at times get worse. And families that want to spend out of pocket, especially in a country where you have a lot of poor people, also have to deny themselves of both immediate needs like food and long-term needs like education, payment for education. And that's not good for household productivity, even in the future. Even in the future. So that would be the way I'll look at it.
All right.
All right. Since we're talking about funding now, in 2001 in Abuja, Nigeria signed a declaration. It's called the Abuja Declaration, and it pledged 15% of the national budget to health. And this is 24 years after that signing was done here in Abuja. It has never crossed 6% of that 15% that was pledged at the declaration. Why do you think that we have a step back from the government regarding funding when it comes to healthcare?
Well, the thing is to remember that the government will probably also sign 15% for education. Will probably also sign 15% for social support in some way. We'll probably need 20% for defense, and especially when you have the kind of insecurity challenges that the country has faced as a whole. And you cannot have more than 100%. It's your revenue that you're going to spend. So it is recognized that that is an aspiration. It does not mean that a government can wake up and decide that at least for this year, next year, is going to do that 15%, maybe because of investments in infrastructure, equipment. Let's get it right. And then the remaining time, the years that are following it, we can now spend money on what I'll call demand side. Let's now be maintaining the system by paying for individuals to get care. So look at the 15% as an aspiration or a pressure figure. The important thing, even if it is 5% you're spending, even if it's 6% that you're voting, how well is it being spent? Is it going to equipment? Is half of it going to payment of salaries? How much of it is left for the medical services, for medical care of people? How efficient is this system? What efficiencies are built into the system? Are you paying out of pocket with that money, or are you using a way of payment that you pay ahead of health services so that you push people towards prevention? Which, if you're preventing malaria, you're not likely to get to the point where you have severe malaria, which is now expensive, needing admission and all of that. Right. So that's what shapes the system better. How much you do. If you don't fix it when you have 5% of your budget, your 15% will be wasted.
All right. From your perspective as a doctor now, and actively in the system, would you say that the very limited percentage of health budgets that has been pumped into the system is adequately and effectively utilized or distributed in the system? From your standpoint, what is it like in our system practically?
I would say that that's a huge challenge, but from the local government level up to the national level.
Okay.
Quite a number of things are being done. I know that the current government is trying to implement what it calls a swap approach, sector-wide approach, so that you can see what is happening across the sector and use your funds better, avoid duplications. And then there's a lot of effort, from the side of health insurance as well, to move funds from that out-of-pocket kind of payment towards health insurance. There's a lot of traction, especially in that area of Nigeria has got, health insurance coverage expansion in the last 2 years, especially. Wow. But there's still a lot to be done. There's a lot to be done to move the Nigerian mindset from going to like tertiary hospitals, teaching hospitals for conditions that could be handled at the primary level. An example, If it's something that, let's say, a health worker at the primary level who you pay a certain amount should handle, should handle within a space of time, 10 minutes, treat malaria, and they are paid for that and they have the capacity to do that. If you take that, if you go to a teaching hospital where a consultant who probably might earn 5 times or whatever, or whatever amount, you go there and it's still 10 minutes that they need to take care of that condition, it's a waste. So dealing with waste is a whole of society action, and we need to come to that point of agreeing that we even want to do it, because many people, you still wake up the next day and they go back to the teaching hospital for simple conditions. Okay. It's a waste of resources in the first place.
Let's talk about the insurance you mentioned earlier on, because again, we saw, according to report, that 1 in every 10 Nigerians had health insurance. Basically, you talked about the fact that there's been a massive improvement in that particular sector within the past 2 years, basically. But again, according to the report, 1 in every 10 Nigerians had or still have health insurance as it is, which also shows that to an extent there's actually a low penetration in that particular aspect, basically. So on what data is available that made you say that there's been a massive investment and expansion, basically, when it comes to the insurance level in the healthcare system here in Nigeria?
So the thing with insurance is that, granted, it's not a simple thing to solve, because there's got to be a level of social solidarity. You have to be willing to make your contributions, even if you don't use the service for that year, and the money goes, right? But that money has helped solve the problem for other people who may have contributed less. So getting a people to that point of solidarity is a journey. And it includes the trust that is also in the system. Health workers responding, those who are covered by insurance, are they telling their stories? There isn't a lot of that Nigerians are doing. And I think we need to do more of it, the users themselves, spontaneously, not government engineered. But to make that to succeed, our challenge is more historical. Nigeria started not very well, and that is a problem. Any country that you begin to cover the citizens by targeting those working for government, it takes a longer time for you to get to where you're going to, because you just cover the government workers and you just feel, look, we've done plenty work, and that's what happened in Nigeria's situation.
So when you're saying coverage, are you saying coverage in the place of insurance, health insurance?
Yes. Okay. Yes. Okay. Yes. Paying insurance premiums for them. Right. So because the reason is that most Nigerians are outside the formal sector. They're in the informal sector. Now, to have a design for the informal sector is not easy. It's something that requires a lot of technical capacity. It requires a lot of solving issues like, they are earning money. People are earning money daily. How do you collect money as much as possible daily from them in small bites?
Right.
Now, that is a big design issue. And, recently, I know there's quite some traction in that direction. If that gets solved, and I believe it will this time, with the leadership that you have at the NHI, it will just unlock a lot of things. There are innovations that have happened around the vulnerable, especially people with fistula, people that need cesarean sections, and all that. That has gone on. But this informal sector side, everyone cooperating from the state to the national level. I say that because there's an assumption that if you have health insurance at the state level, it will cover the very big things. It's not very true. Okay. Most nations succeed when the risk pool is happening, especially at the national level. So, but the states contribute. But then when you have real shocks, the national buffers it. And that's the good thing about having that kind of national pool. So it's the way to go if we're going to universal health coverage. But of course, we need to cooperate more. And I think we can. We can.
So you've talked about cooperation basically. I was actually wanting to find out on what data that was available that made you say there's been a lot of expansion anyways on the place of insurance basically. But I think you are speaking more futuristically, than giving us most of the data that we would require.
Well, for something that started in 2005 and all that, we've gone 20 years, and then in 2 years, the last 2 years, to move from 7% to 10%. Is significant. Whatever is happening made 3% to happen in 2 years, we need to do more of it. That's what I mean.
All right. Okay. Thank you so much, Professor Onoka. Now, Nigeria has, because you made mention of something along the lines of a primary health care, and most people would not need to go to the private hospitals for illnesses that can be taken care of in the primary health care. Now, the Leadership newspaper published saying that Nigeria has 34,000 primary healthcare centers, which makes about 85% of the hospitals and clinics here in Nigeria. But of that number, an estimated 20% only 20% of these hospitals are functional. Now, according to this data, do you think that the primary healthcare centers we have here in Nigeria is equipped enough to handle some of these cases that you made mention of, during your conversation here?
Yeah, very good question. One side of it is that having the closer you have health facilities to people, the better for the country. So numbers are not a problem. We are big as a country, and there are even places that haven't been reached that you don't have a primary health center, like 30 minutes walk or 5 minutes drive to an individual, which is kind of what you would recommend, what you would want to see. So numbers. But the thing is that numbers alone don't make the difference. It is functionality. So functionality is more important than footprint. Okay. So I believe personally that we probably just need, if irrespective of how many numbers we count and all that, we need to be sure that you can have one primary health center in a ward. There are health workers there. There is the equipment that is needed. The data can be captured from the facility straight to a database where you can have live analysis of results. Now, that on its own is challenged by even the federating structure of the country. Will the data pass through the state government first before going centrally? Will it, lots of discussions. Who pays the health worker beyond building that facilities are being built by different entities? In one situation, I had this situation that, somebody really thought he was doing a lot of work and he built a health facility. And when he finished, the people said, well, that they have a quarrel with the people in the next community, and nobody provided health workers. They didn't ask questions very well. And sometimes people build national or local, and then the state says, we actually haven't made the provision for health workers who are going to be deployed there. That is a budget issue, and it can't just happen automatically, and you have dilapidation of those health facilities. But I think we can get it right if we're better focused, if we can focus better. There is quite a lot of work being done by the National Primary Healthcare Development Agency and the state counterparts. But the work that we need to do is still massive. And may I add, the best way of achieving functionality is by seeing that that money follows people, not by funding facilities, but by directly as what we call supply side. Oh, we just buy these, buy equipment, buy materials, buy drugs, and go and spend and go and drop in the facility and expect that angels will come and all of that. That's not the best way of spending money. That's not the best way of making it efficient. The best way is that there are 20 people in this community. There is this health facility that has been built. Now, 20 people are likely to need this set of services based on the data that we have over the course of the year or the month. Now, some will need malaria treatment once, some others 3 times, and all that. And there's always data to solve for that. Now, because of that need, I'm going to send a certain amount of money to you, the facility, which will cover these needs that will come your way for the next 1 month. Now, that will make the health workers there to think efficiently, plan better, know how many health workers they need. If they need additional on volunteers or short-term pay, they can pay for that to provide that service. Not just that you wake up from somewhere, employ 200 people, send them to a health facility that nobody is using, and you have to keep the recurrent costs managed. You have to pay the salaries, whether they work or not. So that approach of money following individuals, which is called demand side financing, if we're going to get it right, if we're going to get to where other countries that have made progress have got to, we have to consolidate financing to follow people identifiable with their NIN. If we are willing to do that, everything you're seeing, including facility issues, will change. They will change. The facilities will know when to maintain things. They'll use some of that money. They'll know when to bring solar panel down because it's cheaper. Instead of spending on electricity, they'll attend to people better, and those people will also demand care in a better way. That's the pathway to universal health coverage.
All right. Now, of course, you mentioned budgeting as it is, and in your recent lecture as well that you made, you estimated that Nigeria may need between 157 trillion naira and 236 trillion naira over the next decade to properly fund universal health coverage, in 2026. Now, that figure actually sounds massive. Do you think this is realistic?
Yes, I mean, money is being spent. The national budget is a national budget, but there's state budgets as well. So, and I didn't come up with the figures myself. Originally, estimates came from a lot of experts, 2019, 2020, and thereabouts. And, there was a Lancet commission a few years ago, and they summarized all those figures. I just blew it up to, what is the actual amount if you draw it, across a 10-year period.
Yeah.
So, but that money isn't impossible. If you have 2 point something coming from somewhere national, think about all the states, aggregate it, and then think about the fact that there is some money that is spent by non-health MDAs. They include in their budgets that has to do with health. Some are paying directly to different organizations for the healthcare of their staff. Some are paying through insurance. Some are paying by just reimbursing everything inefficiently. And then there's all kinds of money goes here and there. People are building things in different ways. So I believe that we have that money. The challenge is the willingness, the courage to channel it through the right sources. Even if you go half of it and all that, you can solve a lot of problems for Nigerians. And then there are still people who can pay anything. They are going to contribute, and they will also sort themselves out.
Okay.
I believe it's possible.
All right.
And,
thank you. Okay. All right, great.
If you add that, you can also look at it from the point of productivity. Health is an investment that can activate productivity in a country. And I think if we look at it like that, it's an investment that is worth it.
All right.
All right. Thank you very much. This will lead me to my very next question. Nigeria has a population of about 230 million people and citizens now. it has one doctor for every 5,000 patients, and this is according to the WHO report. And aside that same report, the number that is expected for a doctor should be about 600 patients per one doctor, but this is far from the expectations of the WHO. Aside that, it says that women are 258 times more likely to die in childbirth here than in the developed world. When we look at this data, there are two ways to frame it. First, a failure of resources or a failure of political will. Which of this do you think is the exact reason we find ourselves here? Or is this distinction even important at this point at all?
It is. I share your sentiments very much. It makes us feel that, look, we're all living in a risky situation, and that's the truth. That's how most Nigerians are living. Doctors are overworked, nurses, other health workers, many have left the country. The next plane that you see out of the country, there are still some doctors. You'll almost always find a doctor in a plane that is leaving every week, or many doctors. So those around are overworked, and truly so. And of course, a major outcome is what you're mentioning: women dying from pregnancy and delivery, and during delivery, and causes related to that. It doesn't speak well of a nation. It doesn't speak well of ours, and I will admit that. But I think a lot of it has to do with, things that have been there, but it requires. It's a system challenge. I would say it's a system design issue, and I mentioned a bit of the reasons for that. If you have like insurance, which is a prepayment approach, it really means that you have some money ahead of the month. If you have money guaranteed ahead of the month, because I know that it's 2 million people that I have guaranteed, that I have there that are likely to need services, it's 2 million people. I will know how many doctors that I'll hire, even if I'm in the private sector, and I have these numbers clear. That's what helps solve it. So that's why I said financing shapes the structure and the outcomes of the health system. It will make me know who I should hire, who I shouldn't hire, the mix, the tasks, and of course, that also will make me know how well and how much I can pay. If you don't have that, you're depending on people strolling in when they are sick, and you're not God, and you're not a witch. You will not be the one mobilizing people to come. And it's not even a good thing that you are mobilizing, which is why they say doctors should not advertise personally their work and their individuals in Nigerian situation. But that does not guarantee, that does not help you with planning. How do you plan when you don't know whether 5 people or 200 people are going to come your way? You can plan. You can only plan when you have funding around that. That's why prepayment will solve our problem. Prepayment so that people can receive, health providers can receive capitation, fee for service, plan their way, the referral network is in place, and then you'll just see the change. You'll just see doctors staying. You see nurses staying. And then, of course, the country also needs a very good plan of what is that shortage and what exactly do we need to do in the medical schools, the nursing schools, physiotherapy, radiotherapy, laboratory, all of that, for filling the gaps, even if people are leaving, but we have enough sufficient to keep as many as possible. But that financing, if you want to shape anything, even in a household, start with financing. Every other thing will fall in place.
Okay, so I'll just take us back a little bit from the question I asked about the 2001 declaration, Abuja declaration that was signed about committing 15% of the budget to healthcare. You made mention of the fact that if we have just 5% and we're able to utilize that 5% effectively, then we might be able to have a more balanced system. But you've also trickled down all of the solutions to the problem in the healthcare sector to financing. So don't you think that it is important that we put a peg at that amount and ensure that the government tries to improve the budget? Because again, you have established that without this proper funding, we will not make any significant progress in the healthcare sector. In 2024 alone, we had about 4,193 doctors leave Nigeria, and 66% of those people went to the UK, which means that the NHS has more doctors, Nigerian doctors, than people from the NHS or that country directly. Don't you think we need to enforce that a bit?
Yeah, it's important to separate funding from financing.
Okay.
So someone can receive, I could give you money, but you know how best to use that money to purchase things. You know which market is better. You know which person sells better. You know the seasons. Okay, I can buy this now, I shouldn't buy this now. But it's the same money. And then somebody else just uses that money, goes to the big, just think of it, goes to the big departmental store and just buys that thing that you could have bought, cheaper, the same quality and all that. The same way that, as an example, you can meet a doctor and they are you meet a doctor with the best stethoscope hanging around his neck, the most expensive. Now he's having the most expensive, wearing the most expensive stethoscope does not mean that he's hearing the right thing. Mm-hmm. Somebody might buy the one that is 2,000 naira, the stethoscope, but his ears are sharp, his mind is smart, he can interpret what he's hearing, and he solves your problem better. Most people will say, look, the other big one, you're paying for hotel services rather than real quality and that kind of thing. So there's a way to have money by that. That's what I mean. And the point I made, and I'll repeat that, if you don't solve that when you have 5%, your 15% will be wasted. Okay. And may I say, for many years, a place like the US had the same life expectancy, which is the ultimate outcome. What's the average life expectancy? It had similar life expectancy, with Cuba. But America was spending like 40 times what Cuba was spending on healthcare. But outcomes, similar. Expenditure, 40 times more. Why? Lots of waste, lots of hotel services, but of course, also investment in research and technology. But Cuba managed things efficiently. That's what I mean. If we don't solve it at 5%, we cannot say that 15% will be used very well.
Okay, so it means more structural reforms, because we are seeing Nigeria's health expenditure per capita about approximately 72% per person, and the US spends about $14,490 on the same. Bangladesh, who has a far smaller GDP, spends comparably to that of the US also. And you have made mention of structuring that with the little amount that we've had. So let's just talk about what structural reforms are even necessary before the money comes to make the difference that we want to see in the healthcare sector.
Yeah, and that's what we've been speaking about since, like those countries. Even there are other countries, Indonesia, you see they spend, they are quite comparable. And the presentation I made last week, I showed that the money for even Ghana and countries that are nearby, Ghana, Kenya, they are not too far away. They are not too far away from what Nigeria spends. But in those countries, out of pocket payment is like 30 to 40%.
Way less.
Nigeria, it is 72%.
Okay.
As long as it's like that, we are wasting money, we are wasteful, and people are being denied care, especially the poor, and we have more than 100 million poor people in the country. As long as that is the case, people will be dying, and those who are sick get worse. The worse you get, the more the pressure on the finances of both the household and the government.
All right. Let's finalize by talking about the concept that you introduced as well, which you call the pro-academic, which talks about someone who combines academic research with policy and implementation skills. Because we see a lot of persons actually carry out some of this research, but of course, the implementation skill is not there. They're not in the position to influence this policy making decisions as it is. How urgently do we need all of this right now in our country, Nigeria?
We needed that. Best time was 10 years ago. 20 years ago. Maybe we are in the 5th best time. I would say we do need people that think like that, and even if they don't, the fact that they have that realization will help them build strategic networks. Networks, you have people who are inside of where decisions are made, that you can easily share your research outputs. An example, interestingly, when I didn't have access to some policy platforms in that manner, but years back, over 12 years ago, I had some study I did related to malaria. Why were women who were coming for antenatal not getting the preventive treatment that they needed for malaria, and not getting enough? And that result came out. I had very clear results, and somehow I didn't even know them then. I took, that was costly though, but I went to the Federal Ministry of Health. I created policy briefs. Researchers and academics typically will focus on their journal articles, and not many people read those journal articles. I don't know how many you have read yourself, but you are advocating for health because of your position, right? So I usually will turn those things into 2 to 4 page, easy to read policy briefs. Look at the problem, look at what the evidence says, look at how you can help by advocacy or by making recommendations at certain levels.
All right.
And then so I make it available to journalists and all that. So that one, I took it actually to some people who were responsible to the Minister of Health at the time, and who were his advisors, and showed them. We had a very great argument in that room, and that way, that 30 minutes, 1 hour that we had was necessary, was important for them. While advising the minister, writing for him, they knew what to write, they knew what to say, with regards to those issues. So the networks are important. Now I think I have stronger networks, and I've also found myself playing some of that role. But we do need them. We need them now. We need the academics to think differently and let the agency that they bring to the table be even more capacitated, so that we solve real problems in Nigeria.
All right. Thanks so much, Prof, for your time with us this morning. I appreciate you. Thank you so much.
Thank you so much for your insights as well.
Oh, thank you very much.
Enjoy the rest of your day.
Thank you. Thank you.
We'll be speaking with Professor Chima Onoka, a professor of public health and health systems economics, and of course we've been talking about the future of healthcare here in our country, Nigeria. Of course, lots of salient points that he has made, and one thing that is certain, the implementation and reforms, of course, that has been talked about in the healthcare system has got to be intensified. And of course, just like you said, we need a lot of these reforms, and we need them right now to ensure that Nigerians can get proper access to healthcare systems in Nigeria.
In all of what Prof has said, the most important thing we have to note is that we don't lack the manpower. We just need structures. We just need policies that favors the people that are actively in the system and are ready to work. Imagine 66% of our doctors are in the UK, working. So yes, just like he has recommended, and thankfully he's someone that is quite knowledgeable about these matters. Just as he has recommended, we're just definitely hoping that the government does what it is within their power to ensure that there's some sort of stability in the healthcare system, and that can be done by focusing on improving the budgets and the implementation of the budgets that have been improved on by, you know, the necessary stakeholders.
All right, sure. With that being said, this is all we're going to be taking on today's edition of the Rapid Done right here on Rapid Television. Do remember that you can follow us on our social media pages across our platforms at Rapid TV. And of course, you can get to watch all our episodes on the YouTube platform, which is at Official Rapid TV. And not to worry, wherever you are in the world, you can get to watch us live using our website, www.arabianradiotv.com. My name is Victor. Okay.
My name is Martha Alo. Thanks for joining us, and we will see you tomorrow.
See you tomorrow.